you all for joining us tonight to talk about MS with the Rocky Mountain MS Center and Dr. Tim Vollmer. I'm Kelsey Lance, the Education Manager at the Rocky Mountain MS Center. I would also like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Biogen, Bristol Myers Squibb, EMD Serono, Genentech, and Novartis. This speaker series is just one piece of our education programming. Currently, all of our programming is available online. We have put together a page of resources relating to COVID-19, including updates from Dr. Enrique Alvarez and Dr. John Corboy, wellness videos, telehealth tips, and a resource guide. Our Spring Education Summit will take place on Saturday, April 10th. You can register at mscenter.org. The best way to stay up to date on our educational programming is to be on our mailing list, which you can sign up for at mscenter.org. Another benefit to our mailing list is EMS News, our monthly e-newsletter. The next edition comes out tomorrow and will include a significant update on COVID and vaccines. And now I'd like to introduce you to Dr. Tim Vollmer. Dr. Vollmer is a graduate of the Stanford University School of Medicine and a former faculty member at the Yale School of Medicine. He is the Director of Neurology Clinical Research at the University of Colorado, the Medical Director of the Rocky Mountain MS Center, and Co-Director of the Rocky Mountain MS Center at University of Colorado. Due to a technical issue tonight, we are joining Dr. Vollmer about 90 seconds into the presentation. Thank you.
So the reason for discontinuing these drugs primarily is if your antibody levels are dropping, since there isn't any other major long-term risk with their use. As long as your antibody levels are not dropping, the risk-benefit profile is very much in favor of benefit in basically all forms of MS. The only area where that begins to change is if patients are over the age of 60, where many patients may be through the active phase of the disease, and even a small risk of these drugs may not be worth the benefit, although research supporting that is still relatively limited, and we won't have a major study to answer those questions until the middle of next year. But at this point, I would say that losing your ability to ambulate safely is a big risk. A fall leading to a fracture or a concussion or subdural hematoma can dramatically increase the disability of this disease. So in general, I would argue that since these, particularly the drugs that we're talking about, rituximab, ocrelizumab, and ofatumumab, are very straightforward drugs that are easy to monitor for safety issues, that as long as you don't have those safety issues, it'd be better to stay on therapy, particularly if you're below the age of 60. And then another question was, it says, I haven't felt any benefits from disease-modifying therapies. In fact, I feel like some symptoms are worse. How do I know if the Ocrevus infusions is even helping? Well, one is to be really clear in your understanding of what the Ocrevus is about. So Ocrevus, rituximab, and Kcentra are all drugs to try to shut off the inflammatory attack on the brain as completely as possible. That's to prevent further damage to the brain so that people don't lose more function than is absolutely necessary. And the reason I say it that way is because if you've already had MS for a number of years and have already accumulated disabilities, then the other thing that damages the brain is the normal effect of aging. And that adds on to the disability of MS. And that, unfortunately, outside of exercise and diet, we don't really have a treatment for. So what your therapeutic expectations are with this drug is that if you're in the early phase disease, then what we really expect is that you're going to have a dramatic decrease in the number of attacks you might have. In fact, it's very rare to have a relapse on these drugs. And in younger patients under the age of 55, the brain is still pretty good at repairing itself. And in those patients, we actually expect patients to get better year after year. However, unfortunately for us, if patients have already had MS for some time and have accumulated some disability and also lost a fair amount of neurons, they've used up that neurological reserve, neurological resilience that allows the brain to recover function to a significant degree. And so in that situation, the primary goal for these therapies is to, again, minimize any further damage into the brain and to try to preserve function. and then use physical therapy and other medications to try to improve function. But we don't necessarily see as much actual recovery of function due to repair in the brain in that situation. Nevertheless, stopping the inflammatory attack and preventing further damage is very good. For example, one person states that he was thinking about stopping it because he has primary progressive MS. He's unable to walk. He really only has a decent function in his right arm and hand. And so I would argue that's probably not the right reason to stop Ocrevus, because preserving function in that hand is critical to your ability to be as independent as you can. And using highly efficacious drugs to protect that hand and arm is a very appropriate therapeutic goal. Simply switching from one immunological therapy to another one isn't necessarily going to improve function in the rest of the body. So the therapeutic goal in this situation is really to protect your right arm and use highly effective therapies. And that could be rituximab, it could be ocrelizumab, it could be Kcentra, it could be natalizumab or Tisabri. The oral drugs could be used, but they're substantially less efficacious. And we see substantially more disease activity and progression of progressive disease in patients who are on the Gilenya type drugs, which is Mayzent and Zeposia, or the Tecfidera and Vumerity drugs. And drugs, when you get down to things like the oral chemotherapy drugs, which are cladribine, which is Mavenclad, and Albagio, which is teriflunomide, those drugs have other negative effects that tend to worsen outcomes for patients because they actually inhibit repair and they also damage the brain. And Albagio has such minimal effect that in most patients, it allows patients to continue to accumulate damage that's irreversible. So it isn't possible to identify a patient with any blood test or any genetic test or anything else and say if you do Gilenya, you're going to do better than if you did on ocrelizumab. The same is true for any of the other drugs. We can't predict how any given patient is going to do on any given agent. However, we know the probability that they will do well on a given agent because that's what we studied in the phase 3 trials. So we know the probability that somebody will stabilize or have minimal disease progression on things like ocrelizumab and Tisabri and those drugs is much higher than it is with many of the oral drugs. And that's the best we can do, is use these therapies to maximize the chance that you're going to get as much effect as you can from the modern therapies that we have, realizing we don't have a cure and we don't have a way to actually repair the brain itself directly yet, although that may be coming. Do you have another question, Kelsey?
We got several questions relating to aging and MS, asking you to elaborate on the risk of B-cell drugs and being over the age of 60. Also, someone over the age of 70 with secondary progressive MS. Would you recommend different treatments for relapsing remitting patients over the age of 60? Just kind of some of that natural history and how treatments might change over time.
Okay. So the natural history of multiple sclerosis untreated is that the disease is most active at onset, most active in young adults and older teenagers. And then at a population level, when you look at the population that's over the age of 35 and you follow them over several years, you find that their risk of having an attack or relapse and the risk of having an MRI lesion is steadily going down. And that continues such that by age 60, the risk of having a new MRI lesion or a relapse is now decreased by 70% at a population level. So the average relapse per patient per year is about 1, an early stage disease. And by the time people get over the age of 60, the average risk of having a relapse during the year is down in the 0.1 range, so it's 10 times lower. So the point of that is just that in order for a population where people have very different rates of relapses to have 70% without evidence of disease activity means that 70% no longer seem to have the inflammatory disease process that's going on. It seems like it's shut off. And we have pathological evidence of that, as well as biomarker and MRI data for that. Problem is that's not true for everybody over the age of 60. There are clearly patients over the age of 60 that have active disease. In fact, I've diagnosed patients in their 70s with new onset multiple sclerosis. And we don't yet have a way to determine who is through the active phase and who is not. So again, John Corboy, my colleague, is directing a large national program, multi-center study to try to answer that question. We'll have the data from that study by middle of next year. And that will tell us what's the risks are of going off therapy versus staying on therapy. In that study, they didn't select any particular therapy. They just used whatever therapy people were on when they came into the study, and then randomized them, and half went off the drug and half stayed on the drugs. And again, we'll get that data next year. And that'll provide more accurate information and possibly better insight into how to select patients for going off therapy. So at this time, for patients that are over the age of 60 in particular, there is what we call equipoise between staying on drug and going off drug. And it means that both are reasonable based on the medical data. They're equally reasonable. I can't say that one is better than the other option in general. There are some patients that I have a sense that they'd be better off staying on therapy because I'm more concerned about their immune system still being very active. But nevertheless, on average, most of the time I don't know. And so either one is possible. And the way I would recommend patients make that decision is to decide which are you concerned more about, the potential risks of the drug or the potential that the MS may reactivate, which most likely won't be a relapse, it'll be progressive disease, so progressive disease, which can be hard to identify. And whichever one you're less comfortable, situation less comfortable being in, is the one I would avoid and do the other one. So in terms of trying to make a decision whether to stay on therapy in terms of the risk, that's pretty easy. It's just a matter, again, of talking with your physicians about what's happening with your B cells and what's happening to your antibody levels. And if you're having frequent infections. So those are the kinds of issues that if your antibody levels are dropping, or your B cells are not being fully depleted, or you're already having recurrent bladder infections or colds or flus or pneumonias, those would be reasons to go off therapy and be monitored clinically because the risk of the drugs may be higher than the risk of the MS reactivating. On the other hand, if you don't have any of those problems, you're tolerating the drug well, then for right now, it's basically an insurance policy to make sure you don't have further inflammation until we have better data in a year or so to make that decision with.
And can you speak a little bit to kind of an older age diagnosis if someone was diagnosed at, say, age 54, but their brain scan doesn't show a lot of activity?
So age itself is not actually a significant criteria for therapy selection, with the exception that I'd be very reluctant to put young people on chemotherapeutic drugs such as Albagio or Mayzent. I'd be very reluctant to treat them with a drug like Lemtrada, which is alemtuzumab, because those drugs, the first two, are chemotherapeutic agents, and they induce mutations in cells and they increase the risk of cancer lifelong. And the problem with Lemtrada is that it also increases the risk of cancer, but it also really disturbs the immune system and leads to the development of other autoimmune diseases, many different kinds of autoimmune diseases, and a number of which unfortunately are fatal. So those are therapies that for young people, I would feel are quite contraindicated. Therapies for young people would be primarily the Tecfidera, Vumerity, Gilenya type drugs, and then ocrelizumab, rituximab, Tisabri, those drugs. And particularly in younger people, we would be using the Ocrevus and Rituxan and Tisabri therapies, because that's, if we treat with very effective agents at the first onset of the disease, then we have a huge impact on the lifelong course of the disease, really minimizing its negative impact on patients over their lifetime. So the earlier we can treat with high efficacy drugs, the better the outcomes, and that's been demonstrated over and over again. So I don't personally view the oral drugs as first-line agents for young people. For older patients, it's the opposite. The issue there is, do they have other health conditions that make a certain class of therapies more risky for them? So for example, if somebody has hypertension or diabetes or cardiovascular disease, then drugs like Gilenya, Zeposia, and Mazan really would be contraindicated because they have significant cardiac effects that would increase the risk of cardiac complications or worsening of the diabetes and those kinds of things. People with prior history of significant stomach problems or gastric stapling or other surgery on the stomach that makes the stomach more sensitive to the side effects of Tecfidera and Vumerity would make those drugs relatively contraindicated. There's not much in the way of contraindications to the use of Tysabri other than if you carry the virus, the JC virus. That drug is very selective. It doesn't really have much in the way of off-target effects. And in fact, might be a preferred drug for patients that have inflammatory bowel disease where it's also approved. And then the anti-CD20s, there again is that people have a history of immune deficiency, frequent infections, and then that would be a relative contraindication, or they are already had low antibody levels, then that would be a relative contraindication, not an absolute one, but a relative contraindication to the use of the anti-CD20 monoclonal antibody drugs. So because the anti-CD20s and Tysabri are monoclonal antibodies and they're so targeted to a very specific target and have very little in the way of bystander side effects, they would still be the preferable drug in older patients unless they had some specific contraindication. So, and then I would also argue that putting older patients on things like Copaxone or Avonex or Rebif, the interference makes no sense whatsoever because those drugs have no detectable effect in patients over the age of 55 and often have relatively difficult to detect benefit for patients under that age. So I don't really see a role for the old injectable drugs anymore. There's no advantages to them, including safety, if you're comparing them based on the risk of a serious health problem. All those injectables do have rare but real serious risk associated with their use, just like the oral drugs and just like intravenous medications. And I had a question here sort of along that line. It's a patient said, I'm very sensitive to medicine and I usually get terrible side effects. I'm currently on Copaxone, but I'm running out of tissue to do the injections in and I need another option. And she said, hopefully one that doesn't suppress the immune system. So the only class of drugs that we have that really doesn't suppress the immune system is the Tecfidera and Vumerity drugs. All the other drugs do work by inhibiting immune function one way or another, the exception being Copaxone, which also does not suppress the immune system. But again, I don't think the injectables really have a role to play. So in terms of the modern therapies, Tecfidera would be the only drug we have that doesn't suppress the immune system. However, having said that, Tecfidera does have a risk of PML, which is a disease that occurs in people that are immunosuppressed, even though it doesn't raise the risk of pneumonia or shingles or other things like that. So there are selective examples that are a problem. And again, we can suppress the immune system to a mild degree without really running much risk of serious infections. It's when we really suppress the immune system with drugs like cladribine or alemtuzumab, Lemtrada, is where we really do see major risks with infections. But in the Tysabri, Ocrevus, rituximab, Kesimpta drugs, that's not a major problem for us. It's a bit more of a problem in terms of infections with Gilenya and Zeposia and Mazan, because they have particularly a risk of shingles infections, which can be serious, particularly involves the eye or something. And they also have a risk of melanoma and basal cell carcinoma. So again, the problem here is that it's not really helpful just to pick out sort of a catchword that is talked about a lot on the internet and is used relatively loosely in conversations as a way to compare these drugs. We really have to sit down and say, what are the risks of a serious health problem? Something that would cause cancer, put you in the hospital, threaten your life. And then you can compare those risks across the drugs, and they have different patterns to them because of the way the drugs work. But nevertheless, that's the risk you're trying to avoid. So thinking about the drugs from the standpoint of the risk of those serious health problems, regardless of what the mechanism is, will allow you to compare the relative safety of the drugs in a much more useful way. Now, safety and tolerability of drugs are two different things. Safety is the risk of having a negative health problem occur. Tolerability is having a side effect that makes you uncomfortable or makes you sick. tolerability issues are hard to predict for individual patients. So some patients will have a lot of nausea, flushing, and tequilaria, and other patients don't have any. Same is true for gilenya, I think. Same is true for Ocrevus. So it's hard to predict how people will tolerate the drugs. But the nice thing about that situation is you can try the drug. If you have the side effects that make the drugs uncomfortable, you can stop them. Whereas with serious health problems, that's a different issue. They come out of the blue and you may not be able to stop them once they occur. So again, I would separate thinking about how tolerable a therapy is to take, how much it impacts your quality of life from the standpoint of making you feel ill, as a separate issue from the risks of the drug causing a serious health problem that might threaten your life. I hope that helps.
And I'm sorry if I missed your answer to this, but it was related to an earlier part. Someone asked, is the end of the inflammatory stage strictly a function of chronological age, or does number of years since disease onset play a role?
It does not appear to be an issue with how long you've had MS. It appears to be an issue related to your age, because the immune system is changing as a function of our age. It's called immune senescence. So senescence is just a term for the negative effects of aging. And the immune system becomes weaker. It's not quite as potent. It begins to make mistakes in how it regulates itself. People are more likely to develop rheumatoid arthritis or lupus or other problems, which are problems of regulation of the immune system. And so it appears to be that immune senescence that's causing the organized immune attack on the brain to begin to diminish and eventually stop. Now, I don't know for sure that that's it, but unfortunately, our immunology colleagues really haven't focused on that issue of MS. And so no one's really tried to answer it in more specific terms from an immune regulation standpoint. So that's the best we can do at this point. So there was a recent study published last week looking at patients who went off therapy and asking what was the risk that they would reactivate. And what it showed, it was a very small study, but they had, I think, half a dozen people that were under age 55, and 70 or 80% of them reactivated their MS and had further evidence of disease activity in terms of relapses, some of which were serious, or new MRI disease activity. Whereas in the patients that were over age 60, none of them reactivated their disease in the year and a half or so they were observed after going off therapy. So that's why right now we use the age range from 55 to 60 as a time point to begin possibly discussing the possibility of going off therapy. But even somebody had gotten it at age 10, which we have cases of that, they're 25 years later, they still need to be on therapy because they're still young enough to they can have serious reactivation of the disease. Okay, so there's a question here on the latest research on microbiome and MS. What does that mean, or what should you learn from it regarding your diet? So the problem with this area of research is that it's extremely complicated. There are millions, if not billions, of different species of viruses, bacteria, and fungi in the gut, on the skin, and the mouth. And exactly how they relate to health is still very complicated. And the reason it's complicated because like any other ecosystem, it's the food sources that are available that determine what species are going to do well and what species are going to do poorly. Same is true for the gut. So if you have primarily a vegetarian diet, there's a certain pattern to the species of bacteria that live in the gut, and they make certain byproducts that may get absorbed into the bloodstream and get distributed to the rest of the body that may have either positive or negative effects. If people are eating more animal protein, that drives a different population of bacteria, Bacteroides and other things, and they produce different byproducts, and those byproducts may have different effects on health. But again, it's extremely complicated. And then in addition to that, there are direct effects of those diets on the human body. So as with meats that have saturated fats, we get cholesterol deposition in our arteries, and with fruits and vegetables, we get more nutrients, but there are other potential risks with those with pesticides and other chemicals that are in them. So I think at this point, what we do know is that optimizing your diet has a very positive impact on your health. Whether that's through changing the microbiome in part or not, I don't know. But we do know that the Mediterranean style diet, and that's just a broad, it's just basically just telling us that eating a variety of foods that includes whole grains, nuts, fruits, vegetables, fish is healthy. And again, exactly why it's healthy is part because of the nutrients that are there, we know, but it also may be in part because of the impact it has on the microbiome. So that's as far as I think you can go in today's world down that particular issue.
I've got a couple of questions about MRIs. How often generally should folks have an MRI? And then also, should a person who is older be having MRIs to evaluate something such as changes in brain volume? They're worried that MS can appear to be silent.
Okay, those are good questions. So the issue is that there is an international consensus statement that came out of the Consortium of MS Centers, and it's been modified. It was just modified a year or two ago. And basically it states that MS patients should be having a brain MRI once a year. The problem with that statement is it flies in the face of reality. And that is that we have a couple dozen different approved disease modifying therapies, and they vary from drugs that have very modest effects on the course of the disease with a large number of people who we would call treatment failures, to drugs that are extremely effective, and there are very few people who are treatment failures, and where the treatment failures aren't so much due to disease activity, they're due more to side effects of the drug, risks of the drug. So if you're on any of the injectables, Copaxone, Alvinix, Rebif, Betacern, any of those, you should be having an MRI every year. And the reason you should be having that MRI every year is for, in hope that either your physician or you will recognize that your disease is still active and you're still accumulating damage and persuade you to go to a more effective therapy. That's the purpose of it. The same is true for the oral drugs. There are some patients that do very well on Gilenya or Tecfidera, and we've monitored them now for 7-8 years now, and they're still doing well. But because there's a fair number of patients who break through and have disease activity, and since most disease activity is clinically silent, 90% plus is clinically silent, in terms of seeing new MRI lesions with no symptoms associated with them. MRIs are again key and should be done every year. However, with Tysabri and Ocrevus, Rituxan, and probably Kcentra, I'm not 100% sure yet there, we have vast experience over the last 10 years using these drugs and following patients. And we initially were doing MRIs every year, and then we hired a epidemiology student to go back and do chart reviews and pull 1,000 MRIs that were done on our patients on these drugs and ask what was the chance that we would see a new lesion, and then what was the chance that based on that MRI we would change treatment. So we looked at 1,000 MRIs. 2% of the MRIs had a report from radiologists saying they saw a new dot, a new spot. Essentially all of them are very small. And then when we asked what was the chance that would actually change treatment, it went to 0. So out of those 1,000 MRIs, not a single one changed the treatment decisions. Now, those MRIs cost $1,500 to $2,500 each. If they were done with gadolinium, that's another $1,000. Gadolinium does accumulate in the body. The MRIs themselves are quite safe, unless you carry a metal article with you into the magnet, which can rip through everything, cause a lot of problems. But realistically, they're quite safe. It's just that the return on investment there is extremely low. So I don't follow routine MRIs in patients on those drugs because it doesn't change practice. What I do is once they've been on therapy for more than 3 months, then we will do a new MRI, non-contrast brain MRI, and that becomes the new baseline. So now we have a way that if the patient comes back a year to 4 years later and it has some symptoms and we want to see the MS active, I've got something to compare to. In that situation, the MRI is useful. If your patient is having symptoms, you're trying to figure out what the cause is. So, so I think you have to tailor the frequency of the MRI to the situation. Now, the issue for older patients is the MRIs remain very important in the management of patients with MS. So there are a couple situations. So one is that patients are not on therapy and they have a new symptom. Depending on the nature of the symptom, it may be more important to evaluate them for stroke and less important to evaluate them from MS. That requires an emergency room evaluation, the CT scan, and then MRI. In more subtle symptoms, then the MRI would be important. However, if they are, say they're age 60 or so, and they're going off therapy, then we would monitor their MRI every year for 3 years at least. And the reason for that is that if they're going to reactivate, so far the data suggests they're going to reactivate within the first 2 years or so. So if we do MRI at year 1, year 2, and year 3, then it gives us a way to see around that. If we don't see any evidence of disease activity, then we may not continue it. However, again, that's a judgment call. So I have some patients that physiologically just don't look like they're 65. They look like they're 45. Those patients, I'd probably continue the MRIs a bit longer. The same is true for some of my patients in their 70s that really look like they're in their early 50s. So again, we don't have a way to measure how senescent the immune system is or any biomarkers to tell us if they're really through the active phase of the disease. Now, our hope is to actually change from MRI, which is still not all that sensitive a way to monitor MS, and go to blood-based biomarkers. So we have technology called Simoa in the lab that allows us to look at very rare molecules in the blood, down in the femtomolar range. And so that allows us to look for molecules being released from the brain due to damage and inflammation going on in the brain. It's not just relevant to us, it's relevant to Alzheimer's disease as well. In fact, there now is a blood test for Alzheimer's disease because we can measure tau protein, which is a brain protein in Alzheimer's disease in the blood. And in multiple sclerosis, we have several different proteins we can monitor, but the key ones are, one is called NFL, or neurofilament light, and one is called GFAP, which is an astrocyte marker. And we know that those go up when the brain is being attacked immunologically in multiple sclerosis. So we're working with a number of different sponsors and stuff to get that test validated so we can move it into the clinic and use that as a way to monitor people at all ages, really, but particularly patients that are going off therapy or patients that are on less efficacious therapies where subclinical disease activity is more likely. And my hope is that that will be into the clinic towards the end of this year. Did I answer the question there, Kelsey?
I think so. And then we had another MRI question asking if we really need contrast with MRIs.
It's a good question. So about 6 years ago, there was a report published that they had done biochemical analysis of human brain in patients who had had gadolinium contrast enhanced scans. And what they showed was that the gadolinium was accumulating in the brain, and it was the amount of gadolinium in the brain was directly related to the number of MRI scans with contrast patients have had. So that caused us all to sort of reevaluate, because up until that time, we really hadn't seen much in the way of risks associated with use of gadolinium outside of the allergic reactions. And so we stopped doing MRIs with contrast as a routine basis. And so where the contrast comes into play is when you really think there's a reasonable chance that you might see active disease. So this is somebody who's early phase disease, you put them on therapy, or somebody's gone off therapy for whatever reason at a younger age where you're more concerned about seeing inflammation, where the chances of inflammation may be 10% or higher, in which case we probably would do the contrast enhanced scan. The reason we don't routinely do them is because it does accumulate in the brain and we're still concerned about safety issues. And so we're just satisfied with looking at the number of white spots and the size of the white spots to determine whether the disease is active. But adding contrast does make the MRI more sensitive because much of the disease activity is occurring in the bed of the old lesions. They're already white spots. And yet you can have ongoing damage with more damage to the nerve fibers, and that's killing neurons going on inside those MS plaques. In fact, that's still a key issue in progressive disease. So there are times where contrast may help you understand a little bit better what's going on inside the old plaques, even if you don't see a new spot on the MRI. So again, it depends on the clinical circumstance and the likelihood that you would actually have a gadolinium enhancing lesion to justify the extra cost and risk associated with it. All the risk is very low.
We had a question asking if you could repeat the negative consequences taking Aubagio.
So Aubagio doesn't have a lot in the way of dramatic benefits or risks. It's an oral chemotherapy drug. It was originally used in rheumatoid arthritis. Its major problem has been liver toxicity. Occasionally patients develop severe liver disease from it. It does work by inhibiting the immune system. It's a relatively modest effect, though. So the issues with it, one is just increasing lifelong cancer risk rates. Less of an issue if you're already 65, but on that other hand, the benefit's pretty low too. But if you have young people, 30s, 40s, 20s, then I worry about lifelong risk of these kind of drugs, because you may not see the consequence of treating for 5 to 10 years later. The other issue with it is that it does suppress the immune system, so there's slightly higher risk of serious infections, but the risk is less than 1 to 2% above background. So a lot of the people who use it are not very impressed by that, but that magnitude of risk is the same as what we have for Ocrevus. And actually, it's not serious infection for Ocrevus, it's normal colds and flus. So there's, I think, some nonchalance about the use of Albagio that probably needs to be put into the context of the other drugs, which don't have those issues. The other issue with Albagio is its impact on fertility, both for men and women. It is a teratogenic drug. It gets deposited in the fatty tissue in the body, and takes more than a year to 2 years for it to actually be leached out of the fat. The only other way to help clean the body from it is to have the patients take relatively large amounts of charcoal or ion exchange resins to try to absorb it that way. So again, I don't really see any advantages of Albagio given the other drugs that we've got.
And I have a couple of symptom management questions, and then I'm going to steer us towards a lot of the COVID questions. But for symptom management, we had people wondering about meds that help with spasticity besides Xanaflex and baclofen, because they feel dopey on those, and also a very dry mouth. And then we also had a question about Impera, and if you have experience treating patients with only mild ambulatory deficits, and did they see improvement with Impera?
Okay. So the first question about spasticity. Spasticity remains a major problem for us in the field. Our therapies are relatively limited, and unfortunately, almost all of them do have cognitive side effects of feeling sedated or drugged or interfering with memory. But in addition to tizanidine and baclofen, there is the benzodiazepines, which are the Valium type drugs. These are things like clonazepam and Valium. And clonazepam is one we tend to use because it has less of the cognitive side effects and doesn't seem to have as much withdrawal symptoms associated with its use. And then beyond that would be the other seizure medications that we use for neuropathic pain. They also can help with spasticity. This is gabapentin, Topamax, Lamictal. So these are all seizure medications that can be tried. Their efficacy is not high, and they all have cognitive side effects as well. After that, we get into devices like intrathecal backroom pump. So the intrathecal backroom pump is using baclofen, but it's injecting a very small dose directly into the spinal fluid that then affects primarily the neurons in the spine, not the neurons in the brain. And so by not delivering it in the blood, where the brain and the spinal cord are both saturated with the drug, and just delivering it to the spinal cord, you get a more selective effect without the cognitive side effects. And particularly patients that have more severe spasticity, in about 80% of people, it works quite well to manage spasticity without really interfering with cognitive function significantly. There's Botox stimulation. Botox is useful if you have relatively small joints or muscles that are being affected. It's not that useful if you're talking about spasticity in an entire leg or in both legs, like that. Then after that, in certain types of severe spasticity, there are surgical procedures where you either destroy the nerve roots that are innervating the muscles and basically paralyze muscles, or you cut the tendons so that the muscles contract, but they don't move the joints. That's particularly true for the Achilles tendon and the tendons of the knees. Obviously, that's not a place you want to be if you don't have to be there. So realistically, baclofen, tizanidine, gabapentin, or Neurontin, and clonazepam would be the top 4 drugs that we would use to try to manage spasticity in patients. And then the other drug that's not FDA approved in the United States, but is approved in Canada and Europe, is the cannabis extracts, which are THC and CBD or cannabidiols. So the approved version of these in Europe is a 50-50 mixture of THC and CBD. And we now have a study going on at the University of Pion, where we also are testing it with the FDA to see whether we can demonstrate enough benefit to get the FDA to approve it. So we do have patients that acquire these through the various outlets here in Colorado and try them. I can't really tell you which ones to try because we really don't know what's in them. But some patients find them helpful, and if you have a reliable vendor that you can have confidence in that they are relatively honest about what's in the gummy bears or the sublingual drops or whatever, then that might be a reasonable thing to try. But again, I can't really tell you where to go or what to use. And then in terms of Ampura, I know Ampura quite well. It's one of the earlier drugs that I worked on developing back in the late 1990s. So worked on it for more than 24 years, actually. And we tried it in many different ways, many different patient populations. It was the intellectual property rights to it were owned by a small company that did not have a lot of money. And so they ended up doing a very focused study just to try to get approval. And that was looking at timed ambulation or walking speed, which is only one of the symptoms that the drug might work for. It could work for almost any MS symptom. But that was one we could measure that the FDA would accept. And so when we did the study, we showed that we could improve the, how long it took somebody to walk 25 feet. And that translated into they could walk farther with a little more stability. And that led to the approval of the drug. However, the dose that was approved was actually the lowest effective dose. The company didn't have enough money to continue the study to look at higher doses. So we don't know if higher doses would have helped more patients or not. And then the problem with, of course, is the seizures. 1% of patients will have a generalized seizure on that drug, which can happen at any time, potentially life-threatening if you're driving or walking upstairs or something. So I find it's useful in about 15% of MS patients, and it can improve ambulation for some patients. For some patients, it's mainly helps them get more strength in their legs so that they can stand at the kitchen counter to cook meals or wash clothes or something, which is important. For other patients, it can decrease tendency for foot drop. So if they can walk pretty well, but as they walk, they get more foot drop because their leg fatigues, and this drug might help keep their foot up so they're less likely to trip and fall. So for patients who have better ambulation, it's probably mostly around foot drop or weakness in the leg that occurs if you're walking more than, say, 100 yards. It might help those kind of symptoms. And it's a matter of trying them, testing them to see whether they really are useful enough to you to justify that risk of seizure, which is the major problem with it.
All right, I'm going to move us into the COVID questions, and there have been quite a few of them. So I'm hoping if you want to just start giving an overview of vaccine safety and efficacy with MS, and then any considerations that people need to think about with their MS drugs, and I will try to prompt us as we go with anything we miss.
All right. So first thing is, as you all know, we have 3 vaccines. And these vaccines are very similar. They're all messenger RNA vaccines. In other words, they're delivering a small fragment of a messenger RNA gene that's been transcribed from DNA. And it gets into your muscle cells when they inject it in your arm, and it causes the muscle cells to make a viral protein, in this case, the spike protein. And that spike protein then gets moved to the surface of the muscle cell and expressed. And that's a place where the immune system is constantly looking for something amiss in the cells and then responds to that and develops an immune response. The Moderna and Pfizer are just messenger RNA. They're just naked messenger RNA that's injected in the muscle. The Johnson & Johnson is the same messenger RNA basically, but it's encapsulated into a viral capsid. So they've been able to develop technology where they have an adenovirus, I believe in their case, where it's genetically engineered that it will go into a cell and it will make a lot of the capsids, little capsules that protect the DNA and RNA of viruses. from the environment, and they've been able to build it so that they can actually put the messenger RNA inside that capsule. So now you have a much easier way to deliver the messenger RNA to the muscle cells, a way that's very stable because the messenger RNA is very protected. So you don't have to freeze it at super low temperatures. It's quite stable at room temperature for a significant amount of time, and it can easily be refrigerated for prolonged storage. But otherwise, it does the same thing. It gets inside the cell, and then the messenger RNA makes the spike protein, which then gets put on the surface of the muscle cell, and the immune system responds to it. The Chinese have two vaccines. They're both older style vaccines. They're both just killed virus. So traditionally, most vaccines in the past have been where you just grow the virus in some kind of a culture media, eggs, chicken eggs or cell lines, and then you purify it, kill it with various chemicals, and then just inject that killed vaccine into the muscle, in which the immune system is responding to lots of different molecules, not just one molecule. And it's effective. It's not the most effective way to do it, but it is effective. And then the Russians also have an adenovirus vector, which is like the Johnson & Johnson, although those replicates a little bit for a short period of time, but they also have a different messenger RNA gene. So they're looking at the S100 protein. And there's dozens of other types of vaccines being developed. So the future vaccination for this disease is quite bright in many different ways. So anyways, the vaccines we have in the United States are pretty much the same in terms of how they work. They're also pretty much the same in terms of how well they work. The key numbers to look at are not the number of people that had transient infection. It's the people that got admitted or died from the disease. And all three vaccines prevent that at essentially 100% level. And that's been verified so far in post-marketing surveillance. The controversy has been about the Johnson & Johnson vaccine, which reported that it had average reduction or protection from coronavirus infection of somewhere between 65 and 85%, depending on which study you looked at and which populations they mixed together. But you can't really compare that study to the Moderna and Pfizer studies because they were done with different outcome measures in different patient populations. They were done in the developed world. Johnson & Johnson was done in South Africa and India. And also the way that they identified people who got coronavirus wasn't by necessarily doing viral testing, is they identified them based on symptoms. And unfortunately, that means that there are patients who didn't really have coronavirus infection that got labeled as having had that infection without having it verified by viral testing. So I would say that the key data we look at in terms of immune responses, protection, hospitalization, severity of disease are essentially identical. And that comes into play when thinking about how to proceed. So the first thing I would say is that the main purpose of getting coronavirus vaccine is to protect you now. Because right now the virus is common in the environment. And if you've not been vaccinated, you still have a substantial chance of ending in the hospital and dying from it. Even if you just look across the entire population, about 1.5% of the population that gets this disease will die from it. And another 3 to 5% will have prolonged hospitalizations. And this is a very bad disease. I mean, these people feel like they can't get a breath. They feel like they're suffocating. And this goes on for months. It's a miserable situation. So even if you survive it, there's many complications from it. So because the risk is high right now, you want to get vaccinated sooner than later. And so trying to fiddle with the subtleties of these studies and the different outcome measures doesn't make any sense because realistically, all of them protect you at the same level from the really severe problems. And so the goal here is to get you vaccinated as soon as possible, whichever one is available to you. Now, from the standpoint of our therapies, if you're on Albagio or Cladribine or alemtuzumab, all three will decrease the efficiency of the vaccine to some degree, but there's nothing you can do about it. Because by the time you went off the drug and allowed the immune system to recover, it'd be 2025. So realistically, on those drugs, you just get vaccinated whenever you can and hope for the best. But most people will get effective vaccination responses on this drug, most. With the injectables, the interferons and Copaxone, and with Tecfidera, they don't really have any significant effect on vaccinations. So with those, you can just ignore them, ignore the MS treatments and just get the vaccines whenever you can. Same is true for Tisabri. It doesn't have any significant effect on vaccination. The ones that do are the Gilenya, Zeposia, Mayzent, and then the Ocrevus, Rituxan, and Kcentra drugs. They do decrease the efficiency of vaccination. However, for the Gilenya type drugs, going off the drug puts you at risk for having a rebound in MS disease activity. So again, there, you just want to get the vaccine done and hope for the best. And again, most people will get a significant immune response and protection from the vaccine. With the rituximab and ocrelizumab type drugs, there is a little bit of adjustment that we can make. Not so much from the timing of the vaccine, because again, it's hard to predict when you're going to get off of the vaccine. So in general, we would say, as soon as you can get it, just get it. The only adjustment that we would make is that if your infusion of Ocrevus or Rituxan or your next sub-Q injection of Kcentra is coming up, we would recommend delaying that for at least 4 weeks after you complete the vaccine cycle. So for Pfizer, that's first injection, second injection 3 weeks later, and then 4 weeks after that, you get your infusion. For Moderna, it's 4 weeks. And then for the Johnson & Johnson vaccine, it's just one injection. So you just get the infusion 4 weeks after you get the first injection. So that's the only adjustment we would recommend making. There's a lot of discussion on the internet about, and a lot from my colleagues trying to sort of guess when would be the optimal place. That is exactly what they're doing. They're guessing. There's no data. There's no published data on immune responses to coronavirus in MS patients on any of these drugs. We're working on trying to get that. We have a study that we're trying to get funded and launched right now to do that. But at this point, delaying it is based on speculation at best. And again, if you delay your vaccination, you're prolonging your risk of exposure to this disease, which could potentially be very tragic for you. So we say get the vaccine. And the other things about the vaccine, though, is it can worsen the symptoms in MS patients. In fact, we've had patients that normally are able to walk pretty normally and then got vaccinated and couldn't get out of bed. And that's because of the fever response. So if your body develops an elevated body temperature, you're going to get more short circuiting in the pre-existing MS plaque, particularly in the spinal cord. And in some patients, they're very sensitive to that and can have a dramatic impact on the disability. So it does not actually provoke new inflammation in the brain, though. There's no evidence for that. So it's just a matter of managing the fever response, which occurs over the first 48 hours, maybe 72 hours after the vaccination. And so you recommend taking the usual couple of Tylenol tablets every 4 hours or ibuprofen every 6 hours, or both of them if you need them, to minimize the fever response. But outside of that, there's no other special risk associated with use of these vaccines in MS patients.
So the vaccines are safe with the current MS DMTs. What about any recommendations for patients who are on the anti-CD20 therapies who have regular COVID exposure? Is there anything special that you would recommend for them?
No. So when I say that all the vaccines are safe to use in MS patients, the only issue for us is really how effective the vaccination is going to be. And again, as I said, we think most people will have effective immune responses, but a slightly higher percentage won't get a significant response, and a slightly higher percentage will get low enough responses. They may be more susceptible to having transient infections or being able to have the infection and shed the virus for a period of time. However, having been vaccinated, our expectation is their chance of having severe disease is dramatically decreased. It's probably not zero, but it's dramatically decreased. In terms of what to do when you're working in an environment where there's potential exposure, is you should be wearing an N95 mask, and depending on what you're doing, potentially gloves that you change regularly, in addition to just washing your hands, maintain distance if you can. But realistically, if you really are in a high-risk environment, the best mask is the N95s, and they are potentially available to non-healthcare workers now, and there's going to be an increasing market for them since the healthcare system seems to have enough of these right now for most of their needs. So if you can get one of those, I would say get an N95 and wear it. There isn't anything else you can do. So in general, CDC guidelines are really trying to minimize your exposure by maintaining distance, using a mask, not gathering in larger groups, being outdoors whenever possible. But if you have to be in an environment where you're potentially exposed or have a high risk of being exposed to people that were infected, and getting an N95 mask is probably the best thing you can do. But remember that transmission of the virus is mostly respiratory through aerosols and droplets, but it also can be transmitted through moist membranes, so the eyes and the mouth. So that's why, in addition, you have to really discipline yourself not to be touching your eyes and your mouth any more than absolutely necessary, even then, only after washing and potentially putting on fresh gloves.
Once someone has received the COVID vaccine, are there tests to check for immune response to the vaccine?
No, the response to the vaccine, unfortunately, is not necessarily detected accurately by the tests that we use to detect past exposure to the virus. So the antibody test that we do when people come in that have been exposed in the past to see whether they have antibodies to it doesn't work for the vaccines. So there are research techniques where we can measure the antibodies to that, and that's part of the study that we're setting up to do. But at this time, there's no recommendation for having any particular blood tests done after vaccination. There's no practical way outside of a research project to really document how well you responded to the vaccine.
And once a patient, particularly on his anti-CD20, has been vaccinated, can they follow the new CDC recommendations about relaxing social distancing, or do they need to be more cautious than average?
No, I would say that they can follow the CDC guidelines at this point. Let me go back just 1 second on vaccine testing. So when you get vaccinated, in general, you do tend to generate antibodies to whatever the vaccine is. But that's not the whole purpose of the vaccination. The vaccine is also meant to induce what's called a cell-mediated immune response, particularly a type of cell called the CD8 T cell. And that's not measured in most clinical tests. It is potentially measurable in the laboratory under research conditions. So one of the problems that we have is that the Valachi study, which was a study of ocrelizumab with 5 other vaccines, not Ocrevus, but not coronavirus, but other vaccines, did show that antibodies were lower. That doesn't necessarily mean people are at higher risk because they didn't measure the T cell responses, which are actually the more important mechanism of eradicating viral infection. So I think that at this point, I don't think we should be quite so pessimistic about being on MS therapies and getting vaccinated for coronavirus, because in fact, we're not seeing any particularly unusual behavior in MS patients around coronavirus. Most of the patients have ended up in the hospital or had bad outcomes, had other risk factors, diabetes, cardiovascular disease, obesity, the usual things. So at this point, I would say that the CDC guidelines on family gatherings or small groups of people where everybody's vaccinated, or if you're grandparents and you're vaccinated, but your grandkids aren't, it's still okay to be with them. Yes, you can follow all those guidelines. There's no other particular things you need to do.
It's been thought that the COVID vaccine might bring on shingles in MS patients on medications. Is this still thought so?
I'm sorry, that it would do what?
It's been thought that the COVID vaccine might bring on shingles in MS patients on medications.
No, MS medications can bring on shingles on their own, but it doesn't have anything to do with coronavirus vaccine. In fact, the only serious complications that we've seen with the coronavirus vaccines has been the immediate allergic reactions and severe allergic reactions. And the risk of that is 1 in 50,000. Your risk of getting hit by lightning in Colorado is 1 in 7,000. So I'd worry more about the lightning than I would about the severe allergic reaction to the coronavirus vaccine. And so the risk of 1 in 50,000, the risk of other significant things were found is that is mainly facial palsy. So a few people will develop weakness in one side of their face that will last several weeks. It's called facial palsy, Bell's palsy. And risk of that is about 1 in 200,000. So possible, but quite rare. With there's been 1 case of transverse myelitis that I know of, maybe 2 cases. But again, we're approaching 100 million people vaccinated and only 2 cases reported. That makes it very unlikely. So again, the coronavirus is the leading cause of death in the United States. And that's the thing we should be worried about. The side effects of these vaccines are remarkably minimal. I mean, we worry a lot more about other vaccines that we use than we do about this vaccine. It's one of the safest ones. seen, also one of the most effective ones we've seen. Hopefully that will translate into other areas of medicine where we really need this technology, including the treatment of MS. I think there was a question about what are our thoughts about the messenger RNA vaccines in the context of treatment push to MS. I think they're very promising. Actually, I think it's something we could do very quickly. So I did a study about 15 years ago where we used DNA in the same way they're using mRNA now. So the DNA is a sequence that encoded myelin basic protein, which is one of the most common proteins in myelin, and we injected that into the arm of patients with the same thought that hopefully that DNA would get inside the muscle cell, make myelin basic protein, put on the surface of the muscle cell, immune system respond to it. However, in that context, where patients don't have inflammatory muscle disease, it's because the muscle itself is sending out signals to the immune system to tell it that we're supposed to be here. Protect us, don't attack us, tolerate us. And that leads to what's called a tolerogenic response, where the immune system tolerates the proteins in the muscle cell. It didn't work, but didn't have particular safety issues either. So with this technology, we could do it much more simply and probably in a more potent way by using the messenger RNA technology to generate whatever protein we want. The problem is that everybody in the world and their uncle thinks that MS is a disease of myelin. It is not a disease of myelin. It's a disease of the brain. It's spinal cord and optic nerve. And all the different structures in those areas can be attacked and destroyed. The reason that people think it's a disease of myelin is twofold. One, because they're not reading Charcot's papers back from 1860 correctly. He clearly points out in his papers that the other cell type, particularly an astrocyte, that he thought was going to be a key player. And all he could do is see it. They didn't have ability to culture or do anything else. But most of it, they describe demyelination because that's the stains they have. And so he classified it as a disseminated inflammation with damage to the brain, stuff like that. But it got converted into demyelinating disease. That's how everything's been taught. And that's been a problem because that has really put the blinders on the field. The other reason is because the animal model that we use to study MS is not MS, but it is an inflammatory disease because of myelin. So myelin proteins, PLP and MOG, MBP, can all be used to generate an inflammatory disease that has some characteristics of MS. And that has funded billions of dollars worth of research over the last 50 years. But we tried extrapolating that animal model into humans with MS based on all the things we learned from the animal model. None of them worked. The only therapy that came from the animal model was Tysabri, and it came for a different reason. So what I'm arguing is that the messenger RNA technology here, I think, is extremely promising, but only if we as a medical field go back and reevaluate what our targets are. And I would argue probably the most promising target is the astrocyte, which is the cell that keeps neurons and myelin-forming cells alive. It's the mother that takes care of everything else and manages everything. It's just like mothers do. They manage business, they manage finances, they manage health, manage food. That's what astrocytes do. They manage that microenvironment. They provide nutrients to the other key cells. They take away waste materials, and they also are part of the immune system. So anyways, that's just a plea that if you get a chance to talk to one of the myelin scientists, is to tell them there is another cell in the brain. It's called an astrocyte, probably a key cell in MS. I do think that there will be studies started. The thing that would limit this is the peculiarity of modern society, and that is that this technology for messenger RNA vaccines has been around for 17 years. And so people have played around with it, thought about it, and there's been many patents filed on its use. And so if somebody's filed a patent on using an mRNA technology to express a certain protein related to MS, but they don't have the money to develop it, it may be that will never make it into development because the company that could have the money to develop it can't get access to the intellectual property. So that's the frustrating part of being on the drug development side that I find really creates chaos in our field.
I had a couple of different questions about shingles vaccines as well. Is there a shingles vaccine that is safe to take while on Rituxan? And then another question about the timing. Someone started their shingles vaccine November 1st, had Ocrevus infusion at the end of January. Should they be worried about when to take the COVID vaccine and the shingles vaccine interaction?
So the vaccine that is safe in MS, and actually is the preferred vaccine today, is called Shingles. And it is a subunit vaccine, so it's purified protein. It's genetically engineered. It does not have any live virus in it. Doesn't have anything that's can cause an infection in it. And it's much more effective than the old vaccine, which actually was the varicella virus, the shingles virus, that was weakened because it was an attenuated live virus that could occasionally cause serious infections. So that's called Zostavax. I would not recommend using Zostavax. Should just use Shingles. And you can get it in any pharmacy because they bought up all the supply. So if you don't have it at the hospital, but they have it. It's 2 vaccine doses given 3 months apart. Timing is not that critical. It's just they get the first vaccine, and then sometime after 3 months, maybe 6 months, maybe 12 months, you get the second one, give a boost. And again, it's designed to give both a cell-mediated immunity and antibody production. In terms of MS therapies, I don't recommend trying to micromanage it. Theoretically, if you're on Ocrevus or Rituxan, then theoretically you might want to try to do it 3 months after your last infusion, because at that point you don't have any of those drugs in your system anymore, but you still have low B cells. And there isn't any study showing that that really works. So I would say just ignore your infusions or your other medications, just get the vaccination whenever you can. In terms of if you've got both coronavirus and the varicella virus or shingles vaccine, is we would recommend separating them by at least a month. Immunologically, the immune system is like the brain. It can do many different things at one time. So I'm not really worried about saturating the immune system. But it helps separate potential side effects of the vaccines. And also both vaccines can cause fever and other side effects. And so it allows us to just separate the risk profile so we know what's causing what. So just 1 month separation between them is fine.
Are there any DMT recommendations that you would give folks who are considering either starting a DMT or taking a DMT in relation to the COVID vaccine? Would you counsel people to do anything different other than what they had originally planned?
Well, so the catch right now is that in the next few months, we have this rapid ramp up of access to coronavirus vaccines. As I said, is the leading cause of death in the United States. Not just you if you get it, but potentially family members around you. So thinking of that from that standpoint, there was a question about should you start with Albagio until vaccinations are over and then go to Ocrevus. I don't know that starting Albagio provides that much of a protection for you because again, it doesn't have any rapid onset of effect, but it may be, depending on what your MS is like and what your risk of a relapse is, it may be reasonable to postpone starting things like Ocrevus or Rituxan or Kcentra until after you've been fully vaccinated, as I said. Again, the problem with starting, we're talking about a matter of maybe 3 or 4 months here. So the problem with starting some other MS therapy as sort of a bridge into that is that almost none of the MS therapies have much of the way of effect in the first 3 months. So you're taking the risk without getting much of the way of benefit. So in general, I would say it's probably not worth trying to start something else and switch over. You might as well just monitor yourself carefully, and if you have symptoms, be evaluated promptly. But otherwise, just wait until you're fully vaccinated and then get started on whatever new drug you're getting started
on. This question will be mostly or related just to folks in Colorado. I know we've got folks from around the country on tonight, but can you speak to anything about MS or the drugs as a reason to be bumped up in vaccine order and phasing?
Yeah, so there is some guidance from the CDC where they were encouraging states to identify patients that were at higher risk of more severe disease, hospitalizations, and death to have them higher in the hierarchy of getting vaccinated. However, the language is pretty vague, but they do have a long list of health conditions they feel do increase the risk of more severe outcomes if you get coronavirus. And then the states have been interpreting that in their own way. In Colorado, we lobbied the state health department to include patients that were on immunosuppressive drugs, which includes MS patients on many of the drugs I've talked about, cancer patients, rheumatoid arthritis patients, lupus patients, autoimmune encephalitis patients, NMO patients. So in our field of immunology, we are suppressing the immune system quite often. And so that is a known risk for more severe outcome based on some of the earlier trials or assumed to be a risk. So in Colorado, patients that are on immunosuppressive drugs were added to the group 1B4. And I don't know if they use that terminology in other states, but here it's called group 1B4. We're currently vaccinating group 1B3, which are anybody over the age, I think, of 59. I think Kelsey knows more about this than I do. And then patients with special risks, and then 1B4 will be in the next group. And then group 2 ultimately be pretty much everybody else. However, the healthcare system in Colorado rebelled against the governor and the state health department in having the healthcare system confirm to the vaccination sites that patients actually had diseases that put them at higher risk or were on drugs that put them at higher risk. We felt it would shut down our medical record system. We wouldn't be able to get anything done. So it's all done based on the honor system. So if you're in the University of Colorado Hospital healthcare system, which is a large system, then the hospital system, which is the largest vaccinator in the state of Colorado, basically just uses medical record system and just puts in keywords that are on the list of things that move people in various groups. You get assigned to a group, they randomize the group, and then they just go down the list and however many vaccine doses they have, and they send you an email from My Health Connection. And you've got 2 days to respond, or they give it to somebody else. And then there are many, many other ways the vaccines are being delivered, and all of them have their own strategies. And frankly, I think that whole system is beginning to fall apart. I would guess by end of March, early April, that it'll be more just on first come, first served type basis, regardless of health condition and age. Maybe age will be kept, but I think health conditions will be just too hard to track down and too hard to be sure about, and too many difficult decisions to make.
Can people on anti-CD20s get any live virus vaccines? And would you recommend revaccination like MMR for patients whose IgG titers dropped below threshold for immunity?
So the issue is that live virus vaccines are actually a bit more complicated now, because the traditional live virus vaccine was the actual virus that caused the disease that was treated with a chemical that weakened it or killed its DNA or RNA. And in general, that's been relatively contraindicated in anti-CD20 monoclonal antibodies. And the reason for that is that the initial use of rituximab back in 1997 was to treat B-cell lymphomas and leukemias. And those patients were treated with the monoclonal antibodies as well as chemotherapies. And there's clearly a risk of a live virus leading to severe infection in such patients. It's not clear that it was actually caused by the rituximab. However, the dose of rituximab they use is much higher than what we use. And nevertheless, that's carried over as a class recommendation by the FDA. So it is generally taught as relatively contraindicated to use attenuated live viruses. However, there's a second kind of live virus, which is the viral vector vaccines, which there are many of those being developed for coronavirus, as well as other diseases. And this is where you use an adenovirus in general. They can use other viruses, but they tend to use adenoviruses. Adenoviruses is a family of viruses that cause the common cold. And they've genetically engineered them so they can replicate, but they don't tend to cause much in the way of symptoms or anything. And then they put the DNA from the virus that causes severe disease, whatever you're trying to treat, along with the adenovirus genes, and then they inject them in, and you get a local infection with the adenovirus that also leads to production of proteins from the virus of interest and leads to immunity. those are probably going to get approved. And in fact, the Russian vaccine, I think, actually is a live adenovirus engineered molecule. The that one, there isn't any precedent for that. It's only been used once before, and that was for Ebola. So at this point, there still be some reluctance, I think, on part of some people to use even that kind of a live virus in vaccine in MS patients on anti-CD20s. On the other hand, as I said, people on anti-CD20 don't really demonstrate much in the way of evidence of immunosuppression in general. And so I think it may be a bit overkill. But that's sort of where we stand. In terms of MMR, this is still debated. So we were concerned about measles, mainly because of really poor public health practices that led to lack of vaccination and led to outbreaks of measles, which can be a devastating disease. But whether to re-immunize our patients when they come in because they don't have detectable measles antibody is still controversial. And there's no simple answer to that. So many people feel that in the ideal world we would do that, but in the real world, you're taking older patients and giving them a live virus, which has more side effects, and you're delaying your ability to start MS therapy probably 3 months. Just getting the drug approved can take us several months. So there's no simple answer to that one. I think it depends on the person. If you have a young person who's going to be going to college, yeah, we would re-immunize with MMR before we would start them on NC20. Somebody in their 60s, probably not.
And I'm sorry we are running out of time, so I will let you pick what research updates you'd like to give this evening. We had questions come in specifically on BTK inhibitors, treatments that rebuild myelin, and stem cell treatments. So whatever you want to touch on, and we'll encourage folks to tune into the Ed Summit for the rest of the updates.
Okay. So stem cells, I don't really have much to say about those. We've talked about them for 20 years. The only stem cell therapy right now is available is bone marrow replacement therapy. There's no evidence that that is a desirable pathway to go for anybody yet, but we do have a large study, the NIH study that we're part of. So people are interested in pursuing that, I would suggest doing it inside the study. The study will be directly comparing hematopoietic stem cell transplant to the highly effective therapies, so Tysabri, Ocrevus, Lemtrada, those kinds of drugs. In terms of stem cells for repair, there aren't any yet. In terms of the next generation MS drugs, the most likely ones to get approved are going to be a class of drugs called BTK, or Bruton tyrosine kinase inhibitors. These are a large class of molecules that are used in cancer and other diseases. It's a promising group. There's at least 6 different companies developing drugs in this area for MS. Some are probably going to be out towards the middle of next year, maybe sooner. Their efficacy so far appears to be similar to Tecfidera and Gilenya. So they'll be in sort of an oral class. They might be a little bit better tolerated, but they do have some potential risk, particularly liver toxicity, which is a major thing. Although I think they would be competitive with the current therapies from a safety and efficacy standpoint in terms of the orals. I don't think realistically they're going to replace what we do with the infusible drugs like Natalizumab or Tysabri or Ocrevus or Rituximab. There is a MS vaccine trial that we have going on. So it's using a myelin protein that's attached to a molecule that causes, we inject it intravenously, and then the liver cells bind to it and present it to the immune system to stimulate the immune system to develop a regulatory response. So we do have a vaccine study going on. And then in terms of neurological repair, the main study we have right now is a monoclonal antibody that helps break up the MS plaque, which may help the nerve cells rewire and reconnect, as well as the myelin-forming cells to make new branches that go out and myelinate nerve fibers. And so that study is ongoing against a monoclonal antibody that's very specialized in terms of what it affects. And then we have submitted a proposal to use a drug called metformin. Metformin is a diabetes drug used in type 2 diabetes, used in at least 5 million Americans, and has reasons that it may help in repair the nervous system as well. And that would be an add-on therapy to whatever other MS therapy people are on. There's another drug, I'm blocking the name, it's not INH, but Anyways, there's a drug we tested earlier that did preserve brain volume. They've been trying to get it into a large clinical trial, but again, it's owned by a small company that doesn't have the ability to really take it further, and so it's been kind of blocked for further development. As far as I know, it's not so far made it into phase 3. So there are a number of different approaches now being pursued for neurological repair. I think that's actually a very promising area, particularly in the near term, because we have metformin, it's a generic drug, it's safe. We have other drugs, statins and other things that might have repair function. And particularly when we have highly effective therapies that can really shut off the inflammatory phase, which then would allow the reparative phase to become more obvious and have bigger impact on function theoretically. I think that this is a promising time for neurological repair for the first time, actually, in my career.
Awesome, thank you. I would like to thank everyone for joining us tonight and for your amazing questions. I'm sorry that we didn't get to all of them. We did have quite a few come in. We will post a link to our evaluation form, and I would request everyone to fill that out. It does help me shape our future education programming, and we're going to try out some polls as well to get a little bit of information. We did record this session, so we will be sending the recording out tomorrow. So anything that you missed that Dr. Vollmer did go over, you can replay. I also want to point out a couple of resources that we have on our website. So Dr. John Corboy has done updates at the last 2 education summits that included a lot of research updates on things like novel therapies, BTK inhibitors. So you can check those out at the spring and fall 2020 Ed Summits. Those are archived on our website. We also have a lot of updates from Dr. Enrique Alvarez and Dr. John Corboy on coronavirus. So if you're interested in, we didn't have a chance to go into how MS is affected by coronavirus, and Dr. Alvarez has gone over that in extensive detail in those updates. He will also be providing another update at the April 10th Education Summit. So I would encourage everyone to sign up for that. When you register through Eventbrite, you also get the slides ahead of time and the handout so you can take better notes. Dr. Vollmer will be giving an update on some of the research updates as well, so he'll be able to go into more detail about those. Tomorrow's issue, I have a lot of things for you guys. Tomorrow's issue of EMS News, it contains a lot of information about the vaccines and updates and a lot of the information that you guys were asking questions about today. So if you aren't already signed up for our email list and you don't receive EMS News tomorrow, you can email me, which is education@mscenter.org, and I will forward that to you. I believe that is all that we had. So thank you guys. And again, please take time to fill out that evaluation when you get it.
Yeah, and thank you all for attending. I appreciate it.
Thanks. Have a great night.
Thanks, Kelsey.